Good afternoon, everybody, and welcome to our webinar on emerging trends in substance use. My name is Mary McCarty-Arias, and I will be your presenter for the next hour. So we're really glad that you're here. I know there's a lot of people online, and we appreciate that. And let me just start by saying that this program is sponsored by the PTTC, the Prevention Technology and Transfer Center Network, and it's part of SAMHSA, Substance Abuse and Mental Health Services Administration. And the one that we are working for is at Rutgers. Some of you may know Claire Neary, who is our contact there, and it is presented through the School of Social Work. Just if you're interested, the PTTC, if you go to their general site, the pttcnetwork.org, you'll be able to get access to almost many of their webinars as we go along. So I know that today I think there's 5 webinars going on throughout the country, so it's really cool that you have access to that. So what I'll ask people to do is open your chat box. If you look on the top and you hit the chat box, sometimes people like to type in their names and let us know who you are and where you're from. You don't have to do that if you don't want to. It gives me an idea of where you're coming from. So just a disclaimer. The development of these training materials was supported by, it's a grant, M. Chappell is the name of the director, Mike Chappell, who is the director of the ATTC, the Addiction Technology and Transfer Center of the Northeast and Caribbean. And usually we are located in New York, and I can see a lot of people coming and signing in from all over the country, so welcome. So the key with this slide, by the way, is that the contents are solely the responsible of the Northeast and Caribbean Addiction Technology Transfer Center and do not necessarily represent the official views of SAMHSA. So I see we have a lot of people from New Mexico, Texas, all over, our friends in New York. The Northeast and Caribbean Addiction Technology Transfer Center, we do, and the same thing with the PTTC, we cover all of New York, all of New Jersey, Puerto Rico, and the Virgin Islands. Except that the good thing about webinars is that people can come from all over the country. Oh, if somebody asked, can you not see anyone? This, by the way, is on WebEx. And with WebEx, you can't see me, I can't see you. You can hear me, I won't be able to hear you. But I will ask people to probably to write in the chat, or if you have questions, you can write them in on the chat as well. So just moving along the slides. Some of you have seen this before. When we do any trainings for the ATTC or the PTTC, we just always want to make sure that we talk about language mattering and how words have power. And we really want to talk about people first. And some of you, if you know me, you know I've said this many times on webinars, but it's just really important when you look at the person with substance use, the person who uses methamphetamines, the person who uses nicotine, it'll start to give you really it'll start to give you a sense of dealing with people first. And even though sometimes the language feels kind of wordy, it's really helpful to do that as well. So there's my picture, and I've been working in the field for many years. I am a vocational rehabilitation counselor by trade and have been training on co-occurring disorders of mental health and substance use, HIV, and vocational rehabilitation for many years. I know that the PTTC deals with prevention. I've worked in treatment, although I tell people my first job out of college was teaching 7th grade. So I have been involved in educational projects for many years as well. Yes, welcome. And again, we see people, and you can see this on the chat. We have people from everywhere up to Alaska, where I have been able to train, by the way, and it was really a gift. All right, good afternoon, everybody, and welcome to the webinar called The Overview of Harm Reduction. My name is Mary McCarty Arias, and I will be your trainer for the next 2 hours. So welcome, glad that you are here. A couple of things before we start. This course is sponsored by the PTTC, the Prevention Technology and Transfer Center. And as some of you know, it is located at Rutgers in the School of Social Work. And I'll tell you later on when I get to my picture about who we work with. I work with the ATTC, and we have a contract with the PTTC. And we're really delighted, actually, to be here and to do this. So I see that people are starting to write in and tell us who you are. So welcome to everybody. Probably I'll tell you this as we go along, is it's good to open up your chat. You go to the top of the slides because with the chat, I will be asking questions, and we'll all give you the opportunity to ask questions as well. So it's interesting too about harm reduction. And what I'll probably ask you to do today is to kind of rent the idea. Some of you may work in harm reduction facilities. Some of you who work or believe in strong abstinence-based recovery, this may be a challenge for some of you. And so if you just kind of rent the idea, but this will be an overview like a harm reduction 101. So this is actually pretty cool. I see some of my friends from New York City. We have people from the West Coast, so maybe you're eating breakfast. Welcome. We have people from upstate New York. Actually, we have people from all over. I'm going to say that's really the cool thing about doing webinars for the jobs that we have. Probably prior to COVID, we would be doing this in person somewhere, and there would be a limit. Now with webinars, we could have really big numbers. So I think that's a really good thing. And I appreciate people being here. This is the week before Thanksgiving or the week of Thanksgiving. And it's probably I don't know if it's an unusual Thanksgiving for many of us. So a couple of things before I get started. This disclaimer, it goes into all our courses, and some of you have seen this many times, but it's still mandatory. And I guess the key, by the way, is that the development of these training materials was supported by a grant. M. Chappell is. Mike Chappell, who is actually my supervisor, he is the director of the ATTC, the Addiction Technology and Transfer Center, which is the Northeast and Caribbean, and we're located in New York City. The key is that even though SAMHSA, which stands for the Substance Abuse and Mental Health Services Administration, ultimately they fund our programs, but the views are from us, they're not from SAMHSA. So that is the required slide. Now here's another one, and this is an important one too. And I think what's really important is that, we talk a lot about people first, about person-centered recovery. So we kind of need to look at that, by the way, from a point of view of language as well. So let's say, for example, we talk about the person with substance use, the person with schizophrenia, the person living with HIV. And by, I think, using the terms, I think it's really important because it'll help you kind of look at people first instead of just saying, oh, that addict, oh, that schizophrenic or whatever. So words are important, and actually voice tone is important, as you can hear when I'm saying those things. And so we really want to support that. And as it says on the bottom, the ATTC network uses affirming language. Hopefully I won't make any mistakes. If I do, you can let me know, to promote the promises of recovery by advancing evidence-based and culturally informed practices. All right, there's my picture that I show for every webinar. I've been in the field for many years. I'm a vocational rehabilitation counselor by trade. I have not worked in treatment in many years, but I used to work in treatment for people with substance use disorders and also for people with co-occurring disorders. And what I often did was to help people get back to work or find employment that was helpful to them. And we also, the ATTC, which is the Addiction Technology and Transfer Center, that's who I work for. And we are located up in Washington Heights, in Manhattan at 168th Street. We're connected to the New York State Psychiatric Institute. The challenge for a lot of us is that I have not been there in many, many months. So that's who we work for. And I will say that we also have a series of webinars and that we do webinars every month. There's a couple of us who are trainers. So if you're interested in some of the topics, please stay tuned. I think the good thing is you can go to the ATTC website, or even the PTTC website, and you'll see what programs are being offered throughout the country and or in your particular area. So great. So I see people from all over. So again, so everybody ready? This course, just so that I put this out there, was adapted from a course that was developed for the AIDS Institute in New York State. And it was developed by the Harm Reduction Coalition, which actually is a wonderful agency that does work actually throughout the whole world and on harm reduction. Oh, we do have somebody from the Virgin Islands. Cool. Welcome. I was fortunate enough to train in St. Croix many years ago. So any invitations, I will go after the pandemic when it's safe. But anyway, so that's the source. So if you want to find out more information, by the way, the Harm Reduction Coalition has some really good trainings as well. Yeah, and as somebody just wrote in, and let me see what you have. Thank you for addressing this topic. Yes, I think a lot of people don't have a clear understanding of harm reduction and how it's applied to different substances, if differently at all. I think, you know, I'm going to say sometimes almost, and I'm going to go to the goal pretty soon, but I think that's the fun thing about harm reduction. And as I was saying before, this may be tough for some of you. Many of my friends who are in abstinence-based recovery think that this is crazy. I remember my late husband, who was in recovery for 30 years before he died, when I used to show him what I was teaching, he was like, I can't believe you're teaching that kind of stuff. So just know yourself. I think the important thing is that your views on things can help your relationship with people, or it can get in the way. I was thinking too about when I've done trainings on harm reduction for the AIDS Institute, how many people have come up to me, and actually they probably said this in the training, and they said they are so grateful for harm reduction because it saved their lives. So you're going to see kind of the whole gamut, but I'm going to say stay open as much as you can. It's good to know. So what are we going to do? This will be an introduction to the basic philosophy and practices of harm reduction. We are going to be talking about sex and drugs, so I'm just putting it out there. And I know too that, see, the PTTC deals with prevention, and some of you can write in with examples, but harm reduction has been shown to work with adolescents as well. So there's an evidence base on that. And one of the things about harm reduction is that it's probably used for many behaviors. So I'll ask questions, but you don't have to answer this. Like, who out there uses seatbelts? Actually, it's the law in many of your places. But so seatbelts really are a harm reduction technique. Do they prevent people from getting hurt? Or do they prevent accidents? Not necessarily. Do they prevent or lower the risk of what might happen? Yes. For those of you who ride bicycles, do you wear a helmet? Does that mean you won't crash? You could, but it also speaks to you. It actually has been shown to lower head injuries or brain injuries when people wear helmets. For anybody who's a football fan, we got the whole country, so I don't know which teams you're rooting for, but if you are watching the NFL and National Football League and you look at the helmets that people wear now, they are they are supposed to prevent people from getting head injuries. And if you were a football fan 20 years ago, the helmets were very different. So that's all harm reduction as well. So this is like a harm reduction 101. And let's see what we're going to do for the objective. So we'll talk about what is harm reduction, and then we'll look at some of the key principles of harm reduction. We'll look at some different options. Some of them will be around substance use. Some of them will be around sexual behavior. We'll also look at the stages of change. We will have some polls, by the way, so that you'll be able to think about some of the feelings that you might have. Okay, so those are the objectives. I think they're pretty self-explanatory. So now I'm going to ask you to write in a question. So I'm going to say probably all 232 people don't have to write in, but when you think about harm reduction, like how would you define it? So if anybody wants to write in, what do you think? Because you took this course, by the way, maybe because you had to or to get the hours, maybe you wanted to learn more about it. But when you hear that term, how do you define it? So please, yeah, to facilitate recovery, thank you. Reducing use of drug, thank you. Using less drugs and alcohol, thank you. Lowering the risk. These are all good answers. Learning to recognize triggers. Working on controllable risk factors, thank you. Gradually reducing drug use, reducing the risk of overdose. Yeah, I think these are all really good response. It's not enabling. Yes, you're going to my next slides, but it does lower the risk. And I'll just encourage you to read as people are writing in. Yes, safer injection site, safer use and safe injection sites. We'll look at that before we finish. So reducing the risk for harm. Yeah, and it's reducing actually the risk of harm of anything, by the way, even though a lot of times we focus on sex and drugs. All right, you can stop actually writing in, and I'll tell you what we've got. This is our working definition, but these are things that you said. Yeah, and actually before I go on, yeah, meeting people where they're at, which I think is sometimes easier said than done. So it's an important piece. So let's look at, we have a couple of slides on what it is, and then we also have a slide on what it's not, by the way, and somebody already addressed that. So what is it? It's a set of practical strategies to reduce, there's always fancy terms, negative consequences of drug use and sexual risk. I think that's self-explanatory, but I think the key here is that it's practical. Like, what can people really do to lower the risk? It incorporates a variety of strategies, including safer techniques. People mentioned that, managed use and abstinence. And again, meets people where they're at, but it doesn't leave them there. I know when I used to teach at NYU, I've taught a lot of trainings, and everybody always says that they want to meet the person where they're at. And sometimes what happens really is that sometimes when somebody tells you where they're at, you really want them, and this is kind of facetious, but you really want them to be where you are. So I think sometimes that's easier said than done. But that's the key is, you know, where are they at? And remember a professor of mine at school used to say, everyone is ready for something. Everyone is ready for something. You just have to figure out and help them figure out what they are ready for. Yeah, and actually, as somebody also wrote, it's also about sometimes reducing the risk for the person and the community as well. So this is the starting definition of what it is. It moves past judgment, and I know if you look at what are some good qualities of a counseling relationship, it's to not judge. So you're not judging the person because they're using a substance or they're having sex or they're doing something you might not do, but it really works to help them change, whatever that is for them. So that's what it is. Here's what it's not. So, oops. it's not like an anything goes, because sometimes people say, oh, harm reduction, that means I can do anything, anytime, wherever I want to. So it's really not an anything goes. And it doesn't encourage, because sometimes people think harm reduction encourages or condones. It doesn't condone or enable drug use. And by the way, it does not exclude abstinence-based treatment as well. So there's often a continuum of where people are. And for some people, they might prefer abstinence. Other people might not be ready for it. So why is there a need? It does reduce stigma, and stigma is often a belief, right? Or the definition of stigma, it's a belief, and it is, I mean, the history of the word stigma had to do with actually being burned or being stamped with a number or a picture. So to reduce the stigma of substance use, and you all know this intellectually, by the way, but when you look at disabilities and actually the hierarchy of disabilities, the disabilities that often are the most stigmatized are substance use, mental health, and HIV. Why people blame you for getting them. They think that, oh, if you just said no, you wouldn't be where you are. But we know that if just say no worked, none of us would have jobs. So it does start to reduce the stigma. It increases trust and improves engagement with clients. I remember people telling me stories about how this is a story where a current counselor told me that when they wanted to get into treatment, they walked into a treatment center and they asked if they could they could talk to somebody. And at the time, they knew they thought they were going to drug treatment, so they decided to drink and drug before they get there. And the person at the desk said, you know what? You come back when you're not so drunk, and then we'll talk. And the person said that they left and they didn't go into treatment for about 4.5 years after that. So that piece was really strong in them avoiding getting into treatment. So we really have to kind of look at that. Some of you, by the way, are different job cultures where harm reduction may work, and in some cases it might not. So just you want to know that for yourselves. But it does improve individual and community health, and somebody mentioned that before. Okay, so what we're going to do, we're going to attempt to do this, is to do some polls. And what I told Clyde I would do is I am going to read the questions. Oh, wait, you don't have to do them yet, Clyde. Oops, I guess we are doing them. Hold on one sec. Okay. Here's what we're going to do. And the way our Zoom works is there are going to be 4 polls to answer, and I'm going to review each of them before you can vote. So I don't know if that sounds weird, but there'll be 4 polls to answer. The responses will be anonymous, so I'll be able to see the percentages of responses, but there will be no names attached. And so you can think about the question, but you don't have to feel the need to provide the politically correct response. So let me go through them, and then Clyde's going to launch it, but just not yet. So think about this. Program participants are open to talking to me about their drug use. Do you strongly agree, disagree, or strongly disagree? So you'll see that after I go through all of these. Here's the second one. The most effective message a prevention specialist can share is abstinence from any drug use. Strongly agree, disagree, strongly disagree. All right, the next one. At work, I am comfortable offering sexual harm reduction options that do not offer 100%. Do you strongly agree? Do you agree? Do you disagree? Or do you strongly disagree? And then the last one before we ask you to vote, poll number 4. People who use drugs are more concerned about their next drug buy instead of taking care of themselves. So strongly agree, disagree, or strongly disagree. So Clyde, if you would launch the polls now, please. All right, so you can see, by the way, at least I can see on mine, on the right-hand side, if you would, you have about a minute to answer those questions. So program participants are open to talking to me about their drug use. Please fill in whatever answer you would like to. The most effective message a prevention specialist can share is abstinence. Please answer those questions. So at work, I am comfortable offering sexual harm reduction options that do not offer 100%. And people who use drugs are more concerned about their next drug buy instead of taking care of themselves. So I think what would be helpful is to answer them. And then I think you put on the bottom submit, and then we'll see what you came up with. So Clyde, you can tell me when people have responded. All right, thanks for, got it. Okay, what I'm going to do is I'm going to stay on these and we'll kind of have some discussions about that before I go back to the slides. So that, just looking, I can see actually the number. So again, I don't see your name. So program participants are open to talking to me about their drug use. It seems like 31 out of you strongly agree. 83 out of you agree. Actually, that seems to be most the more common one: disagree and strongly disagree. And a fair amount of people put no answer. I think maybe we did this too quickly. I'm going to say that, and I hope you could still hear me, is that one of the reasons we start to ask that question is because sometimes you want people to feel comfortable talking to you. Now, this again, for prevention programs might be a bit different, and you could let me know that later on. But there is a doctor in New York named Dr. Sharon Stampfliff, and she's a kind of one of the gurus of harm reduction. And what she said was she would often talk to people, and first of all, her voice tone was really calming, and people trusted her. And she would sometimes say to people, rather than saying you should stop using crack cocaine, she'd say, and she was working with people around treatment adherence for HIV. She'd say, you know what, I would prefer that you stopped using crack cocaine, but if you're not going to use it, let's talk about how you can use safely. And she said it so kindly that people could really get it. And so they would tell her things that they wouldn't tell to other people. So I think that's kind of the question behind the question with poll 1. Poll 2, let me see what we've got. The most effective message a prevention specialist can share is abstinence from any drug use. We've got small number. Actually, most people said actually you disagree. So that's kind of a harm reduction use. Many of you probably, we didn't give you enough time to answer. And it's kind of like the question behind the question is for you to kind of really know where you are on that. The third one, at work, I am comfortable offering sexual harm reduction options that do not offer 100% protection. One of the things about talking about actually sex and drugs is they can be real uncomfortable for people. And so just to know, it seems like a fair amount of you agree that you are comfortable, and maybe a fair amount of people didn't answer the question. And then again, the last one is people who use drugs are more concerned about their next drug buy instead of taking care of themselves. and most people put you disagree. All right. It's really kind of the attitude towards people who use drugs. So I'm going to say, Clyde, you can close the polls, and then I will put the slides back up. I will share them. And here we are again. So I'm not sure how that worked for people. It was one of those things we decided to try to use polls because we thought it would be a good opportunity to give you to do something else, actually to do something while you're doing the training. So it looks like also, by the way, that a lot of you put your answers in the chat, and that's cool too. So it was our experiment. Let me just go back to why we asked some of the questions. Yeah, I think we kind of went over this, and I think one of the things too is that if you assess where you are, it's always knowing what's your stuff, when does your stuff help, when does it get in the way. So I appreciate everybody doing that. I'm going to say one of the reasons we were going to try the poll is we would really make it anonymous. And so obviously we can see your answers, and that's okay. Obviously people felt comfortable doing that. So thanks. It was our experiment for the webinar before Thanksgiving. So let me go on. All right. So kind of moving on, and this is stages of change is an important part of harm reduction, and many of you have probably had courses on this. If you haven't, I'd say take a whole course on it. But I think the important thing and the reason it's in harm reduction is that you really want to help people, figure out where they are on the stages of change. So just some of the history, stages of change was done by two doctors, Doctors Prochaska and DiClemente, and they were working on smoking cessation. So actually, I think smoking cessation might be something that, for those of you who are in prevention, you may be working with. And what they found was that when people were going through or kind of looking to give up cigarettes or tobacco, that they went through very specific periods or very specific areas before they kind of really got it. So it was like different stages and I think the good thing is you can kind of take any behavior and put it on stages of change. So just to kind of do this as a quick one, I was just thinking, by the way, if you're at Thanksgiving dinner with your family, it's probably better not to assess their stages of change around food, alcohol, whatever it is. You can get in trouble for that. But in terms of stages of change, pre-contemplation means you're not considering it. So you don't even know, a lot of times people don't know they have a problem. So it's before thinking about it. So if somebody is not doesn't think they have a problem with alcohol or marijuana, again, using some of for adolescents, they could be in pre-contemplation. Ideally, what could happen with pre-contemplation when you give them the correct or an intervention that works, people get to contemplation. And so in contemplation, people are thinking about it. To me, this is I'm going to say it's not one of the easier stages, but when people are thinking about it, you have stuff to work with. And you know that you can take any behavior and you could be in contemplation about it for the rest of your life. But our job, in a sense, is to really kind of move people to the next stage. So contemplation, thinking about it, people are ambivalent, and motivational interviewing it deals with the ambivalence around it, around any behavior. Some people will go from contemplation to preparation, and they're planning to do it. It's interesting too, because when you think about going into treatment for anything or giving up a substance, this is like the worst time to do it, from Thanksgiving through, I'm going to say through Three Kings, so that for those of you who are in recovery, you know that this can be really difficult time. And sometimes when you work in drug treatment, you don't have a lot of people coming in. They'll usually wait till after the first of the year. So preparation means you're planning to do it. The challenge, by the way, is that sometimes people are planning to do it, but they don't have the skills and don't know what to do. And I'll go over the interventions, I think, as well. So sometimes people are planning to do it, they move to action, which is doing it. And a lot of times with stages of change, they'll look at it at the beginning, like 3 to 6 months. And so, for example, when AA talks about 90 meetings in 90 days, there's something about doing or changing a behavior for 90 days that starts to kind of get ingrained. Then people go to maintenance, meaning they're staying with it, and it becomes part of their life. And then for some people, not everybody, they return to use. So they stop doing it. And then the key is, if people do relapse, what do? You can get them back on that circle and find out really where they are. I think the key is that it has to be a behavior. Somebody, I was doing a training once, and I was asking people to look at any kind of behavior they were doing, or I guess they might have been assessing people at home. And somebody said, I said, pick a behavior. They said, doing the dishes. All right. So doing the dishes, pre-contemplation might be, I'm not doing it. If you think this is a weird one, hang with me on this one. Contemplation might be, I'm thinking about doing it, but usually, and actually the key, by the way, is if you want to find out if somebody's in pre-contemplation, if you say to somebody, do you see the need to give up alcohol or to stop smoking or do the dishes? And they say, nope, they're definitely in pre-contemplation. With contemplation, you'll hear the word but. I'm thinking about giving up tobacco, but all my friends are doing it at school. I'm thinking about stopping vaping, but I can't because everybody's doing it and I'm the person who has the vaping equipment. And so thinking about it. And then, as I said, preparation. The whole thing with the dishes might not work so much, but the person actually, they wanted the person not just to do the dishes, they wanted the person to be happy about it. And we were saying is, you don't have to be happy about doing the behavior, but it's important really that it is a behavior. So I think the good thing is, by the way, you can take any behavior, and if people are using 2 or 3 substances, they can get a different stage for a different substance. So let's take somebody, an adolescent who's smoking cigarettes. They can be, so smoking cigarettes would be one of the behaviors. They could also, if they're vaping marijuana, another behavior. So you could get a different stage of change for each of those behaviors. Got it? So moving right along. If you have any questions, again, feel free to respond or ask. So getting back to kind of the definition or the principles of harm reduction, and what I will do is I'll explain them and then I'll ask you which one you like the best. How's that? So here's some of the principles. And there are 6 of them. So the first one is health and dignity. And Counseling 101, when you look at kind of the core qualities, one of the core qualities I think that's important is to respect somebody regardless of what they've done. And you know that sometimes when people are telling you things they've done, especially in terms of sex or drugs, it may not be something you would do. It may be something you disagree with a lot, but people, can they tell you whether you respect them or not? You bet. So just respecting people regardless of what they've done. The second one is participant centered. So the participant is the lead person, and it kind of even goes with I think sometimes with participant involvement, but who's really the expert on the person? They are. So participant centered, so they're the lead. Participant involvement. One of the things that helps with that is if you have a client advisory board or you have clients on your advisory boards, and then you can get some really good information. For many of our clients, they have not had a voice or a choice, and by giving them that is really a very strong thing to work with. Having suggestion boxes like in the schools, so that the clients or the people that you're working with can feel like they're part of. Self-rule is, as I said, the client is the expert. And, you know, we say that in a training, by the way, and that sometimes when we're actually doing it, we don't say that. But again, the client really is the expert. And again, people will change when they are ready. Recognition of inequalities and injustices, you know that not just these days, but probably forever and ever back is that kind of the impact of poverty, class, racism, past traumas, isolation, discrimination. So that's just to kind of look at that and kind of take that into account, because sometimes what happens is you might think that somebody can change a behavior. I mean, think about, for example, the pandemic. We're told, by the way, wash your hands for 20 seconds. How do you do that if you're homeless and you don't have enough water or you don't have enough soap? So some of the things that we're told to do, not everybody can do. So that again, we could talk about. I think one of the things about harm reduction, which is good, is it does recognize inequalities and injustices, and it takes that into account with behavior change. And then practical and realistic. I don't know if anybody's a cook out there, but I'll speak from the eye. If I were using a cookbook that's really complicated, and in the second sentence it starts telling me to do something I don't know how to do, I just stop it and say, I'm going to make something else that I already know. So you want it to be easy to follow, like one of those easy cookbooks, or it's like when you go on YouTube and they really teach you pretty easily. Some people are really good on YouTube, and if you want to find out, how to use Zoom, how do you make a turkey? There's a lot. Some people are really good, but a lot of times they're practical and realistic. So here's a question I will ask, by the way. If you look at those principles, actually, let's start with the first question will be, which one resonates for you and why? Which one resonates for you? And if you feel like writing in, fine, and if you don't, that's okay too. But as you look at them, health and dignity, participant-centered, participant involvement, participant self-rule, recognition of inequalities and injustices, practical and realistic. So question is, please write in to the chat, which one resonates for you? Thank you. And actually, if you tell us why too. So I see actually the first two, thank you, are recognition of inequalities and injustices. The third one, so that seems to be the one that so far everybody's writing in. Participant involvement, health and dignity, because everyone deserves a second chance. Health and dignity again. Practical and realistic, yes. We have to make it simple for people. Participant centered. Thanks everybody for writing in. Yeah, sometimes things get glossed over. And again, people are writing participant centered. And then I see there's a lot of the recognition of inequalities and injustices. Thank you, everybody. Health and dignity, participant centered. Yeah, and as somebody wrote, health and dignity, if health and dignity are not good, the rest will be a struggle. Yeah, according to Maslow, yes. Thanks, everybody. My second question, so those are the ones that resonated, and I don't know if you'll get the same answers for this, but here's the question. What do you think is out of those six, what do you think is the most challenging? What do you think is the most challenging? Could be for you. What are the most challenging? So if you would write in the chat, that would be great. participant self-rule. Yeah, it depends too on your agencies, human rights and dignity, self-rule. Okay, a lot of people now are writing for this one, participant self-rule. Interesting. I will ask you, by the way, since that seems to be the common one, is what is it about participant self-rule that made you write that in as a challenge? And participant involvement. So we're getting actually different answers for this one, but what are some of the reasons around self-rule and participant involvement? What made you write that one? There may be a lot of barriers that prevent, yeah, absolutely. Health and dignity, seeing what they need and waiting on them to come to the better action or decision. Bringing it to the participant level is challenging, yes. Yeah, so it's always like interesting because you kind of know intellectually what some of the responses are, but when it comes to practicality, it's different. As somebody wrote, they may refuse help. Yeah, the obstacles in receiving care, which are really big, and I think they're more difficult today with COVID. Okay, somebody wrote, if the participant has too much control, they may resist change. It reminds me, by the way, sometimes if you're doing a group and let's say it's on relapse or substance use, and actually if you have a group of people who are all in pre-contemplation, it doesn't work so well because they will get together and some of actually this is going against like self-rule, but it's something that sometimes doesn't always work. Oh yeah, drug reinforcement is powerful. Obviously, that's what people do. No teletherapy, that is a challenge. Yeah, and just basic needs and strategies. Okay, so we'll actually talk a little bit about substance use first. So here's another question. All right, so this question is, it's not a joke question, by the way. Why do people use drugs? This is not a question, by the way, where you have to be personal. I'm not saying why do you use drugs or why did you used to use drugs, but why do people use drugs? If you would, please write in the chat. Why do people use drugs? To self-medicate, to feel better, to regulate an emotion, escape reality. Oh, good. You can see actually there's lots of reasons. And they're going up there pretty quickly on the chat. They're stressed, coping, masking pain, escape, self-trauma, because others do, feel different, temporary feeling that they get, feeling normal, you think it's fun. Self-medication, a big one. Experimentation. So again, for those of you in prevention, and also a sense of belonging, benefits of into relationships, they're bored, peer pressure, they like it to forget problems, and comorbidity. So yeah, people are continuing to struggle with mental health, numb oneself from reality. And probably peer pressure. Again, when you look at, for example, and actually peer pressure is often for adolescents, but I think it's for other people as well. So yeah, genetics playing a part of it. Yeah, and people are, some of the answers that keep coming up are to self-medicate, family hereditary trauma, relaxation, drugs hijack the brain, stress release. And as you know, during COVID, the numbers of substance use of alcohol has really gone up, of other drugs has also gone up. And actually, for those of you who are in states like in Oregon and the state of Washington and California, the numbers of people going to the places where you buy marijuana, which are considered essential businesses, is really high. Same thing like with liquor stores. So liquor stores are considered essential businesses. So they did not close during a lot of, at least if you're not from New York, by the way, and depending on where you are actually in the world, you may have had different things as far as social distancing. Oh yeah, and you can order it on, actually you can order anything online. So you can get alcohol and you can get lots of other drugs online too. So the key and probably the question behind the question is, people use drugs for a variety of reasons. And again, I'm thinking of the holidays. So I don't know if it's good that Thanksgiving is in some places not going to be as big a party as it usually is, or maybe that's going to make people drink more. I don't know. But people use for a variety of reasons, and they could be, and I could break it down into some of the things you said. They use for biological reasons, they use for psychological reasons, social and spiritual, and again, a lot of those overlap. So let's see what we have. And actually, this is what I just said. And people have different reasons for using substances. So when you look at actually some of the factors surrounding these behaviors, in fact, as from a harm reduction point of view, and I don't know if some of you are out there are working in harm reduction sites, but one of the things that people do is they'll brainstorm with people. Let's look at, if you're smoking cigarettes, let's look at some of the options. If you don't want to give it up totally, what can you do? And so sometimes that brainstorming, I think, is really good, but to kind of take into account that people are using for a variety of reasons. So when people, for example, are self-medicating or they're medicating for mental illness, then it may be difficult for them to start thinking about wanting to give up a substance, including tobacco, by the way. So that is something to keep in mind. Yeah, and thanks, Ellen. Generational trauma, yes, definitely. I was just thinking, my colleague Diana Padilla has been doing a lot of courses on culture and bias lately. So hopefully, if she's doing them for the ATTC and the PTTC, you'll be able to get to go to some of her courses because they're really good. And again, the good thing about webinars is we can have lots of people. All right, so substance use. Here's some other things to think about. The reason we actually look at the drug, the set, and the setting is to also look at the whole drug use in context. So for example, I'm going to start at the top where it says drug. So we look at, for example, it says there, the drug use, how it's used, how much is used, and the drug pharmacology. So it's really looking at, what is the drug? What is it cut with? So in some places, and actually this may be determined geographically, so many of the drugs that a lot of the heroin that people are using is cut with fentanyl. And so it's the drug itself. And actually we're just doing something, actually in December, the ATTC, I'm going to be doing a series of webinars on stimulants. It's from the stimulant package of the ATTC. And so we'll talk about cocaine and methamphetamines. And it'll be 3 webinars, like in 3 different weeks, going through that. And part of what we'll start to look at is who's using what, why are they using it, what are some of the trends, so that we can kind of look also at the drug itself, and then kind of also look at it in context. So if we go to setting, we've got the physical, social, economic, cultural, and emotional background piece. So setting also goes to, and this is where I think it kind of, when we're talking about, I think some of the things that you answered before, is that, unstable housing. So if you have unstable housing, what does that mean in terms of harm reduction? What might that mean in terms of your ability to take care of yourselves? Access to clean water. So sometimes in harm reduction, we'll encourage people to clean their paraphernalia, but do they have access to clean water? How about for many people, they're reusing used needles and using alone, And these are all some things to keep in mind around the setting. So, for example, sometimes people choose to use alone. Actually, a good friend of mine in recovery says that he used to always like to use alone because he didn't want to share his drugs with anybody. But we know there's like pros and cons to that. So if somebody's using alone, what might that mean in terms of danger of overdosing? Sometimes when people are in relationships, they're injected by another person. So what's the setting that's going on as well? And then also the set, which is about the mindset, the demographics and social characteristics, physical and mental health, interpersonal skills. So what else is going on with the person? So I don't know if hopefully that makes sense, but it really gets to the context. So it's not always so simple like don't do this or do this, but there's many factors that go into a person's drug use. And that's actually where harm reduction, I think, will come into play. On the next slide, here's a variety of harm reduction interventions around substance use. And I'll go over them, but I just was taking some notes, by the way, about, actually, we'll start with syringe exchange programs. So syringe exchange programs are places where you bring the needles that you've used, you give them to the person at the site, and they'll give you clean needles. Actually, somebody wrote me something privately. I just want to see what it says. One harm reduction topic I'm looking forward to is gaining input is providing harm reduction supplies to clients. I worked for an agency that does harm reduction that provides clients with bubble packs. Yep. There's a policy to provide these supplies once a week. Is this beneficial for client goals to reduce? And when is the client ready? Actually, yes. What she just said is an important piece, so that if, for example, there are like safer injection kits, there are safer crack cocaine kits. So actually, yes, being able to give people something is helpful. And yes, I think it's good. The challenge, by the way, is, we could say, okay, buy condoms, do this. People don't always have the money to do that or the access. So yes, that is really an important piece about really working with people where they are and providing them with access. So yeah, that would go under this, on this slide as well. Yeah, and different deterra bags for prescription drug harm reduction. So there's a whole variety of things that people are using. So I appreciate people writing in. For those of you who are in the state of Washington, actually syringe exchange programs were started in the late 1980s in Tacoma, Washington. And, it's interesting because for many years, people in the Northwest had very low levels of HIV. They unfortunately had high levels of Hep C because we didn't always know what the impact of that. But yes, they've been used for a while. And actually, yes, using syringe disposal programs, those are all parts of harm reduction. And, the key is, by the way, when you do offer these things, it takes away, again, the stigma of it and provides people access to what they might use. So syringe exchange programs, SEPs, they're called, and it's sometimes helpful to know at your site where they are. This may vary according to some of the states where you are. They have been shown to work. There's a lot of evidence, by the way. Now, if you're thinking, why would I want to do that? Why would I encourage people to use drugs? Then you'll know where you are in terms of harm reduction, by the way, that you might not be too close to it, but you might want to be thinking about you're reducing the risk of HIV. You may be reducing the risk of just other health things. I was thinking there was my sister's a nurse in Seattle, and they were one of the first places to have some of their shelters, or I think it's one of the shelters, they had what they called wet houses, so that you could drink there. Now everybody's like saying, why would you want to let people drink? But obviously people are going to be drinking anyway. And you can get this on YouTube, by the way, because I was listening to people talk about how helpful it was for them to be in one of these, quote, wet houses. And what they said was that this man was talking about, he said, when I was able to drink in this house, I could keep track of how much I was drinking. I drank in a much safer way than if I were drinking on the street. So I would say go to YouTube and find out some of that, but there's other ways I think that people are looking at. And actually, my sister, as I said, she's a nurse and used to work in the ER in downtown Seattle, and they found that when there were, quote, wet houses, they had less people from those houses showing up in the ER. So from a health point of view, it's also helpful too. So syringe exchange programs, they work. Expanded syringe access program, that means that you can go into a pharmacy and buy syringes. And, I always encourage people, go to your local pharmacy, if you go to CVS or whatever place you go to, and, find out about that. So usually what some of the rules are is that, oh yeah, Narcan too. Yes, definitely, definitely. And safer injection information. Yeah, I may get to that at the bottom, but I think that's important as you're saying it. So I think what it speaks to is that there's so many different kinds of things to do. So these are just some of them, but I appreciate again people writing in what you're doing. Going back to buying syringes in a pharmacy. They have to be behind the pharmacy, by the way, so they won't be like in the front of CVS or, like I said, whichever Walgreens. And they are supposed to be, by the way, they're supposed to not ask you your name. I think you're supposed to be at least 18 years of age to get them. So if you're in high school and prevention programs, that may not be something that you could do or want to do. I think schools also bring up different kind of rules about harm reduction. So just know kind of what the rules are. But that has worked well for some people. I remember going to CVS and asking the pharmacist, about what they were doing, how much they cost. And she said she was pretty cool with it. And she said the only thing was at first, when people would come to buy syringes, that they'd go straight into the bathroom next to where the pharmacy was at CVS. And she was afraid that when they put the needles into the garbage pail, that the employees would get needle sticks. So she just put a sharps container in there. And I think people also get nervous about police being around there, but they've been working. They've been working as well. Since people are writing this in, I'm going to actually go to what you're saying. Actually, giving safer injection information is also really important. And, there's a lot of things like, I don't know about you. Well, I'm not a nurse, but if you went to nursing school, right, they teach you how to inject. For a lot of people, they had to learn on the street. And so, as I've often asked a lot of my friends, how did you learn? And they usually had somebody who taught them. But there's a lot of things that people don't know. And so if you Google that, I know the AIDS Institute in New York has a whole list of things. And it's, for example, like, where's the best place to inject? And so, for example, I knew people, when I worked in treatment, a lot of people would say like their favorite places were to like inject in their neck or their penis or different parts of their body. And those were actually places that were more dangerous to inject. So I think it's important to kind of help people. Also, people sometimes inject in their ankles because then people can't see the track marks. But it takes long for the drug to go from your ankle to your heart, to your brain, or I guess it goes to your heart, to your lungs, to your heart, and to your brain. And that sometimes people will overdose because they think they got bad stuff or it's not working. So I'm reading what people are saying. Thank you. In addition to having a syringe exchange program, we also provide education and information. Yeah, on naloxone kits, very, very important. Safer injection supplies. You're doing HIV and Hep C testing, MAT, medication-assisted treatment. Yeah, and actually having all those, and again, thank you so much for writing those in, because those are a lot of the options, and you want to go with options, and people can figure out for themselves what works for them. So let's see. my friends in Binghamton are writing too, and I know that I had a problem with heroin like since I started training there way back. Deterra prescription deactivation bags and prescription lock boxes from the Finger Lakes Prevention Resource Center, so all free. Some people who inject have a person that they call the doctor who is helping them with injecting in lieu of sharing drugs. Yeah, it's almost like a safer injection person. Yeah, fentanyl test strips is another thing that is important as well. It's interesting because what people have told me kind of on the street is they may use the fentanyl test strips because they really want to make sure they're getting fentanyl. But again, they're making the decision about what they do. So those are all, again, harm reductions around substance use. So thanks again, everybody, for writing those in. The third one, by the way, cleaning injection drug equipment. I don't know if people do that so much anymore. Kind of in the old days, we used to teach people how to clean their equipment. Although traditionally people used to keep their equipment clean, by the way, like in the 1950s, I've been told. I was not there yet. So that is important. Some of you are talking about giving people information like syringes, like how do people know which kind of needle to go? Do you want a thin one? Do you want a thicker one? And again, injection sites, where on the body is it safe to inject and where is not? If some of you, if you're hearing this for the first time and it's making you cringe, I would just say kind of go with it. But again, it kind of goes to what's harm reduction? How are we going to help people feel better or reduce? I don't like to use the word reduce the harm. It's like when you Google a definition and it's of harm reduction and it says reduce the harm. That's exactly what we know already. But again, how do you help people safely? Makes sense? So there's a whole variety of things that you can do. And people have written in a lot of things. I know many of the people who I've been working with are actually doing trainings on how to use Narcan and also making sure that the people who get Narcan are people who might want to use it. So I think that is important. So, and somebody wrote that. So those are all, again, part of harm reduction. So again, it's not like stopping the drug use. It's, again, using safely. So if somebody overdoses, then it's important, again, to keep them alive. I think the interesting thing is some of you have found out that is if you give somebody Narcan after they've overdosed, usually they're really kind of very angry when they come to because they'll think that you ruined their high and their drug. So don't take that personally. And it's kind of part of the process. Yeah, and actually going back to even harm reduction, when people are using alone, sometimes it's helpful to let people know that they are going to be using alone and also let them tell you where their Narcan is. Let's see. Somebody, aren't we all on mute? Yes, I think you are, by the way. You can all do the chat and open up Zoom. Usually you can unmute people. WebEx, we usually can't. So these are just some things around substances. Now, I also put in, again, this kind of goes to adolescents as well, and I put in the information about some alcohol, and this again comes from the Harm Reduction Institute. So, and these are things that sometimes or people have used for a long time. So here's some situational strategies. Drinking at home. Now, that's not for me to say if I'm a parent that I'm going to tell my child to drink at home. That's a whole nother conversation. But sometimes drinking at home is safer than being out and maybe driving after you've been drinking and or walking or getting into fights or being in places where you get into trouble. Another thing is, and many of you are familiar with this, is controlling your glass. So it's a harm reduction technique. Like if you go into a club or you go out with somebody, and then you have to go to the ladies' room or the men's room, that you take your glass with you, or you make sure that you are controlling it so that when you are away, like in the ladies' room, that somebody's not putting a roofie into alcohol. So that's a harm reduction technique. Planning transportation. So how are you going to get home? And these days with Uber and Lyft, it does make it a lot easier. Remember when I was younger, I always made, before I was married and probably was out in New York City, I always made sure I had enough money for a taxi. But now I have an Uber account or a Lyft account if anything happens. So, but planning it in advance. And I think sometimes women have to worry about those things in a different way than men. That's all part of harm reduction. For some people, it's scheduling when they're going to drink, and that works for some people. Another thing people do also, and you can use this, by the way, with other substances. Sometimes people will have abstinence days, and I remembered somebody told me, actually, this was kind of an interesting one. The goal for the person, they ate at Popeyes every day, and so their goal was only to eat at Popeyes 4 days a week. Now, you know, Popeyes, that's good, tastes good, but maybe not the healthiest. So what they did was they lowered the amount of days that they went to Popeyes. So I guess you could call those abstinence days. So sometimes people are figuring out for themselves if there's 7 days in a week, which days would it be easy to not drink? Which days might it be more difficult? Yeah, and as somebody wrote in, the other issues that youth are ordering alcohol and drinking at home. Yes. You know, again, it's some of the challenges with being able to order stuff from Amazon and get it at home. So it provides different challenges. Another thing is eating first and staying hydrated. So if somebody is going to drink, it's better that they eat first. You know that if somebody drinks on an empty stomach, they'll feel the effects of it. Now, for some people, they prefer bar-only drinking, but as a friend of mine in recovery always said that he never wanted to go to a bar because he thought it was terrible that you had to pay $15 for a drink when you could just go to the liquor store and buy like a whole bottle. So for some people, it's like a control thing. Charting the drink, and that's kind of, it's like a contingency management thing you could look at, and just scheduling. I worked with somebody, there was a client who said that he could lower the amount he was using. And I think it was during, in fact, I know it was during the World Series, and he was a big baseball fan. And he said that he would drink while the Yankees were playing, but the days that there were no games, he wouldn't drink. So you could tell that that was a while ago because the Yankees haven't been in the World Series, I think, since 2009. So the key is working with people around what works for them. All right, so my segue too. So again, we could probably do a lot more not on a webinar, and hopefully maybe I can come in person to your site at some point. And so here's a question. Why do people, we're going from drugs to sex. Why do people have sex? This is not like, why do you have sex? But why do people have sex? So if you would, write in. For money, yes. Thank you. Intimacy, power, pleasure, to feel good, to reproduce, procreate, relax, connection, comfort, pleasure, power, pressure, anger, to connect, hope, peer pressure, again, for young people, intimacy, control. You can see, and again, I know that many of you know how to read. So you can see that people have sex for a variety of reasons. I think sometimes when I've done this in person, that sometimes we'll get like 40 answers on a newsprint. And many of those are things that you said. I think what wasn't in there was revenge sex. So people have sex for a variety of reasons, but you can see that it's a combination of connection, yeah, and money and love. So there's a variety of reasons. Let me just respond to a person who wrote about alcohol control strategies. These additional alcohol strategies sound like the alcoholic in denial, trying to control it while still learning all the power, the cunning, baffling, powerful allure of the substance. I'm going to say if, yeah, it's all possible. I think it'll be important to realize that some of what you think will influence, not, sorry, I'm stuttering because I want to give a kind of an answer that might sound, let me just think on this. You know, many of you, depending on where you're from, or your backgrounds or experiences, if you look at the person who's drinking as somebody who's going to get over on you, and do they do that sometimes? Sure. Can harm reduction or controlled use be a manipulation? Maybe. I don't know, but it's just something to kind of think about. And you don't have to agree with anything we say, by the way. And also, if you work in a harm reduction site, it's important to know your stuff. Okay, going back to sex. So people have for a variety of reasons. And this again, we're talking harm reduction. So young people, by the way, for as those of you in prevention programs, all probably of the same reasons. So some of the determinants of sexual activity decisions, you know, sometimes in a training they'll call social determinants of behavior, and which is kind of a fancy term for what else is going on for the person. So unstable housing can affect somebody's decisions about sex. People had already said, by the way, about exchanging sex for drugs. Hygiene, I think I mentioned before. Some of the things you want to do, it's like washing your hands, you're not going to be able to do that. And then poverty also influences, and people I think had written in this that sometimes people don't have access to care, or the perception that they don't have access to care. Some of you are at rural sites, by the way, and I know everybody's doing telehealth, but not everybody has access to a computer and access to care in a sense. Also, you could be encouraging people to use condoms, but they cost money. And I know some of you are saying that you give them out for free, which is a really good thing. So there's female condoms, male condoms. Female condoms actually are very effective. They're more expensive. And so it's actually phone sex. Yeah, phone sex actually would be safer sex. Oh, and we offer, oh, sorry, that's not what you meant. That's what I was thinking of. We offered temporary tablets and smartphones when we were out of the office. I think, again, as people do that, I think that is really important. So I think the key, by the way, is that sometimes people may want to have safer sex. You know, we use the term safer, not safe, because actually the safest sex would be no sex. But everybody defines that very differently. Yeah, if people are addicted to sex, which is common, by the way, when people have been using methamphetamines or cocaine, there's treatment for that because then that's kind of a whole nother training, but I think it's an important part of why people are having sex. Thanks, Ellen, for writing that. So there's a lot of reasons as to why people can take care of themselves or not be able to do safer sex. Here's some things to look at. Condoms and lube. You know, for a lot of people, they say they want to have, I've been working a lot with people who are using methamphetamines, and sometimes they don't want to use condoms. They'd rather have anal sex without a condom. But even if they just use lube, it reduces the amount, it reduces actually the danger of transmitting HIV or hepatitis C. So these are some, and I think the key is you give people the menu and help them figure out what they want to do. You just read what people have written. Yeah. Yeah, cocaine while using sex, very common. And again, the challenge is somebody gives up cocaine or methamphetamines, and there's that association of using the drug and having sex. So many of you in treatment work with people around that. Yeah, the thing about female condoms, they are expensive. Some people are giving out them for free, but not everybody. This takes away the protective powers from women, not just in preventing pregnancy, but preventing sexually transmitted. Absolutely. I remember once the AIDS Institute, we did a lot of trainings on the female condom, and we thought, oh, this is cool because women are going to be able to make some choices about how they protect themselves. And then I think what happened is people the idea didn't catch on so much. And actually the companies that made condoms said actually men are using them. So men are sometimes using them for anal sex where they'll take out that ring and use it. And it's been, again, very helpful for preventing HIV. Yeah, there's a lot of things that come into account, by the way. As I'm saying this, by the way, if you work for a Catholic organization, you may be told not to share a lot of this information. So I would say know who you work for and what the values are, because I don't want to get into trouble for that. I know, for example, at Fordham University, when we did trainings, and it's a Catholic university, at one point, he did a training, you couldn't really bring in any kind of paraphernalia like condoms or teach people how to, but you were allowed to tell people they could go down to Bronx Aid Services down the street. So let me just say, work within the context of who you work for and how to get people the message. In terms of risk reduction around sex, the activity actually, people sometimes change the activity. So for example, anal sex has the highest risk of transmission of HIV, followed by vaginal, and oral sex has very low, not no necessarily, although actually in a lot of cases now they will say no, but it's a very low level. So sometimes people will make decisions about what activities they're going to do to lower their risk. PrEP stands for pre-exposure prophylaxis, and you might see those commercials on television about PrEP. It is a medication that is given to people who are HIV negative, and it's to keep them negative. So I know it also, I remember at one point we thought a lot of women would use it, especially if they were in a discordant relationship, but a lot of young people, a lot of young men are using it. It doesn't prevent other STIs like gonorrhea or syphilis. Oh yeah, thanks, Charity. The type of activity for sexual activity harm reduction, I was able to encourage a client to do webcam activity rather than in person, and that's safer sex. So yes, and these days, since everybody's doing Zoom, people have been using Zoom for sex for I don't know, for a long time. I was working at a place called Acrea, which is now as part of Gay Men's Health Crisis. And so I remember one of the guys was telling me, you think you're just using Zoom now for trainings? We've been using it for a long time, but it's safer sex. Testing around HIV or any kind of testing. And then during COVID, I'm not sure, I think that the AIDS Institute gave out something about if you're kissing somebody, keep the mask on. But you may have heard of other things that are going on. So again, this is just kind of going through some of these different activities for drugs and sex. And again, if you want me to go back and do a further training and talk about these in greater detail, I would be glad to. As people have questions, and I appreciate, again, people are writing in. And because the next question I'm going to ask, and this is, since it's the PTTC, the Prevention Technology and Transfer Center, I'm going to ask you if you are in prevention. So we just looked at what's harm reduction. You kind of looked at your own stuff and feelings about harm reduction, or at least as a start, and then looked at some specifics around sex, drugs and sex. So what would help me, by the way, is for those of you in prevention programs, is how can you use this information? How can you use this information? So if you would just write in, and you could also put in actually any kind of questions that you have. So some of you may be in prevention in high schools, actually in elementary schools and in colleges. And some of you are in a variety of places. So how can you use this in prevention? So if you would just write in, that would be great. Yeah, it'll decrease the stigma. Yes, thank you, Dolly, for writing. Is there a hashtag you recommend to support harm reduction? You know what? I don't know the answer to that, but you could ask people about that. Do you mean should we make up a hashtag? Or if you Google it, by the way, you'll get a lot of information. Being able to explain and educate around harm reduction can help lower the stigma. Yes, definitely. To educate the patient on the options as a teaching tool. Yeah, I could use it in groups and individuals, and I think that's a good way to do it. Education, community education through outreach, just to educate. Good information to provide to anyone from teenagers to young adults, patients, and now people over 50. Yeah, we could do, a whole course on actually HIV for people over the age of 50, because HIV actually nationally is turned into actually a disease of older, like the graying of it, although new infections are of young people between the ages of 25. So that's why if you're doing any kind of work in colleges or in high school, that's where the new infections are. But many people have been living with HIV for many years. So a lot of the people who are over the age of 50 are long-term survivors. Although it's interesting because sometimes people get infected after the age of 50 because they didn't kind of grow up when they were told to use condoms, and so that's another thing. But generally, it's something to keep in mind. Yeah, giving options, alternatives. Yeah, and actually, a lot of the things with harm reduction is to give people options, because like I think I was saying before, if you told you're doing a prevention program and you say to somebody, you shouldn't use drugs, guess what? People are gonna say, why should I listen to her? Why should I listen to him? So it's not always like if it were 100%, again, people would do, they probably wouldn't even do what you tell them to do. They might do the opposite. So I think that's why it's important to give people options. I was thinking, for example, I knew somebody who smoked 2 packs of cigarettes a day. And as part of her harm reduction, she got it down to 4 cigarettes. So think about it, going from 40 to 4. I thought that was really good. And from a harm reduction point of view, that to me was a success. Now, somebody said to her, but you're still smoking 4 cigarettes. But think about it. The decrease in harm around anything that has to do with smoking, the amount of money that people spend on cigarettes are pretty expensive, and just kind of the social aspect. So she was really proud of it. So you have to always be careful, because sometimes when somebody tells you they do something and you don't think it's like the best thing, you need to look at where they are. Yeah, thanks. So giving options, alternatives to drugs, and that's part of actually for some of the prevention programs. Obviously, that's a really good thing. With the appropriate framing of the discussion, use information in male and female support groups in high school. Yes, that would be a good thing. Somebody wrote, I was educated by my parents of the danger of drugs and alcohol. So if more parents could educate their children at home, I guess they would all know their children to stay away from it. Or yeah, maybe not, right? In an ideal world, people would get a lot of the information that we teach at home, but that doesn't always happen. And sometimes people do the opposite of what their parents tell them to do. Yes, Carmen wrote, however, females who are in new relationships might have unprotected sex because they are no longer getting pregnant. Yes, or are in monogamous relationships. The big challenge, by the way, for women getting infected with HIV is they think they're in a relationship with one person, and the person they're in a relationship either is injecting drugs or has another partner. Yeah, maybe, and again, you can agree or disagree with me when I say about parents telling. I think one of the things to look at is, how comfortable are people, let's say at home, talking about things. Many smokers tout vaping as a form of harm reduction. Yeah, you know what? That one's a challenge, by the way. I think Diana's doing a course on vaping because vaping, one of the big challenges is that there's all kinds of chemicals in it. So people thought initially like it would be a great way to go from smoking cigarettes to vaping to not smoking, but it doesn't, hasn't seemed, it's still very questionable. And so, yeah, I agree on that one, but maybe Diana can do the course on that. Yes, and as somebody said, let's remember, education does not save us from addiction. Just teaching people doesn't change behavior, so we know that. So thank you. Yeah, reviewing the benefits. Oh, kind of going back to stages of change. If somebody's in contemplation, you can review the benefits and sometimes the risks. As an intervention, you could put in a lot of things like you can kind of weight it so that there's lots of benefits the person gets, and they can figure that out as well. Through outreach, yeah, through Facebook groups, there's all kinds of things. There's so many great approaches to harm reduction. There's not, yeah, and that's thanks, Judy, for saying there's not one size fits all. So information provides options, and we want to provide options, and we want people to keep coming back because sometimes if you tell people they have to do something and it's like very black and white, they don't come back, and that's not helpful. So giving the participants the options, yeah, and again, the risk. And obviously people are gonna change. I mean, make their own decisions based on that. Yeah, thanks. Risk or rewards balance. Yeah, so that's an intervention for contemplation. So if you're working in a prevention program, it's like, okay, what are the benefits of not smoking? What are some of the risks? And again, you kind of play with that balance sheet. Good. Other questions? Be an ally with the participants. And that's what it kind of goes to, when we start at the beginning of not judging the person, and being an ally, working with them. And actually, when you're an ally with them, then they'll tell you what they're doing and then you can work on it. Thanks. These are all good things. So I'm hopeful that, again, that some of this was helpful. Again, it was kind of an intro to harm reduction. So other questions that I can answer. Actually, and I don't know if this is like a fun way to end, but you think about if you're invited to Thanksgiving dinner. Oh, this is my own harm reduction. I happen to like desserts. So if I go to a place and I know there's going to be 4 desserts, here's my harm reduction. I know I'm going to pick out the best dessert out of the 4. This is my plan, and eat 1 dessert, and that will prevent me from eating 4 desserts. So sometimes this can be used. Actually, it's been used for eating disorders as well. So so if you look at your plan for Thanksgiving, see if maybe you are using harm reduction. So I think it's important to kind of figure that out. Or think for yourselves. Think for yourselves, what are things you do to reduce harm in a variety of things? Yeah, that's what yes, Weight Watchers uses that. Actually, I am a lifetime member, so they practice what are we gonna eat? Yeah, so this kind of makes it concrete also. So if it's a food thing, you can decide to eat smaller portions. Yep. And that's one way. And I think people have to figure out what works for them. So if you say, I'm going to eat all 4 and I'll eat a small portion, then you do that and you see if it works. And then if it doesn't, you figure out next time you might have to figure that out. Yeah, these are risk and protective factors. But some of it is about, as I'm thinking about Thanksgiving, some of the plans, and actually even like, look, wearing masks, that's a harm reduction technique. So wearing a mask is like 96% prevents you from getting COVID. So there's that 4%, but still you want to figure out for yourself, what you're going to do. And I know that seems to be sometimes political. I'm going to say from my point of view, I'm a Dr. Fauci fan, and so wearing the mask to me is an important thing. So, you can kind of figure out for yourselves. But I think bottom line is you can't tell people what to do, even if they're young. You can encourage them to do things. You can provide options. You can find out why they're doing what they're doing. Like, why is somebody smoking with their friends? What are they getting out of it? There must be something they're getting out of it, or they wouldn't do it. So those are just things I think you can kind of look at in terms of, let's say, smoking cessation or working with smoking marijuana. And yeah, for actually somebody wrote you can't older mature. Oh, you can't. Do you mean you can't tell older mature folks what to do? Absolutely. I think it's the same thing. You know what? And maybe I could start to kind of end with this. If you look at any time you've changed a behavior and somebody told you what to do and they were demanded that you change the behavior, did you do it? Maybe you did. So for some of you who are in the criminal justice system, you may have a little bit more leverage because people have a choice. Do I use substances? Do I not use substances? Or do I go to jail? But anytime people are told, ordered, you demand, people tend to have this idea of doing the opposite. Yes, it's okay. Are there evidence-based harm reduction-based drug prevention programs geared towards college age? Actually, yes, I'm going to say I Google it. I tend to use the NIDA, the National Institute of Drug Abuse, SAMHSA, Substance Use Mental Health Services Administration. But according to the literature, that the drug, actually, there's probably a lot. And I know if Claire Neary's on, she's at Rutgers, and they may be able to give you some very specific things. So I would say, Claire, I'm not sure you're on, but if you go to the PTTC website and you put that question in there, I think you'll get some really specific things, because you can also get access to what's going on throughout the country in terms of college. I do know that actually New Jersey was one of the first places, at Rutgers was one of the first places to have sober dorms. And now lots of places have them. Okay, thanks. Let's see. Charity, having worked in a harm reduction homeless shelter, I found the greatest value was it allowed a person to feel safe, come through the doors, which often connected the person to recourse. And that's the key is we want people to come back. So it kind of goes, if we went to the beginning piece about being non-judgmental, not giving people respect, that's what gets people to come back. And you know what? It kind of goes back. Some of you have been on my course on trauma-informed care. The big important thing about trauma-informed care is, one, how do you create safety for people? And two, how do you not re-traumatize them? And so creating safety for people is really important. And I think during COVID, it's sometimes difficult because we might not feel safe about certain things. But as you create safety for people, that's what gets them to keep coming back. So thank you for sharing that. So it speaks to, by the way, that this works in a variety of places, including shelters. Let's see, the question is, do some drug education and relapse prevention programs are harm reduction? Some are, by the way, and some are not. I think what happens with relapse is that the key is, if somebody does relapse, that we welcome them back and we kind of get them back to another stage, another intervention. And, sometimes we'll say that relapse is part of the process. It doesn't have to be, but for many people it is. To reflect on high-risk situations. Those are all good things, by the way, for those of you who are doing relapse prevention groups. I'm sure you have a lot to work with, like how are you going to get through Thanksgiving dinner? Lots of people I know go to those marathon meetings or figure out ways. Actually, the good thing about meetings being on Zoom for a lot of people is you don't have to leave the house. Although for some people, being in the house is dangerous. So, but yeah, it's helping people figure out for themselves, how am I going to get through these holidays? And again, people make choices about them. Some people don't like to go. I think there was a comedian who said this is like the first time you have a good excuse not to go spend time with your family. So everybody seems to be traveling now. So, but yeah, so these are all things I think that are helpful, or I hope they're helpful to you. So this again was kind of the, I don't know, an app. I always say these webinars are kind of appetizers where you start to look at a topic. So this is an overview. I would say that you could probably Google, and you will get copies of the slides, by the way, but you can Google lots of, actually the Harm Reduction Coalition is one of the best places. Actually, for the person who asked the question before, they'll have the answers to it too, or they'll have people who can answer those questions. So again, I hope it was helpful. Many of you know I put this picture actually at the end of most of my, actually almost all my webinars, because oh, somebody says, can you do it with groups? Yes. So that hope, and actually that kind of goes to what the person was saying about who worked in the homeless shelter. When you welcome people, you provide hope. And I'm not talking about fake hope, but hope is a gift that we give to people. So I like to kind of keep it, and hope is something that we kind of, you can't really give somebody something you don't have. So I think it's important really to do that. So I'll just throw that out as kind of hope. Picture of the tree. Picture's worth 1,000 words, so I should probably be quiet, but you can kind of look at that. I think when you get a picture, copies of the slides that will be there.